Now, the next talk is by Dr. Anna Elias on ethambutol toxicity, all you need to know. Dr. Anna is senior consultant in Giridhara Hospital and she has immense experience in seeing patients with an ethambutol toxicity, and she will be elaborating on the topic. Over to you, Dr. Anna.
Yeah. Thank you. Good morning. I will be talking about ethambutol toxicity, all that you need to know. Ethambutol is an antibiotic with antimicrobial and antitubercular properties. It is bacteriostatic against actively growing TB bacilli, and it works by obstructing the formation of the Mycobacterium cell wall. It was first introduced in 1961, but exactly a year later, Carr and Henkind first reported ethambutol-induced optic neuropathy. So unfortunately, one serious and vision-threatening side effect of ethambutol is toxic optic neuropathy. And the prevalence of ocular toxicity ranges from 1 to 2.5% with the recommended dosage of 15 milligram per kg. The toxicity is dose-dependent, as you can see from the table. What is the exact mechanism? See, the neurotoxic effect of ethambutol, exact mechanism is not known, but it is believed that the metal chelating effect of this drug may be responsible. It chelates copper and zinc. So as a metal chelator, ethambutol can disrupt oxidative phosphorylation and it can affect the mitochondrial function. So defective mitochondrial function compromises the effective axonal transport. See, RGCs are susceptible to ethambutol damage because of the high cellular content of mitochondria. So this is a ganglion cell and this is the nucleus. You can see that this is the mitochondria. So ethambutol actually causes the accumulation of reactive oxygen species, and this causes spores to develop in the mitochondria, and from these spores cytochrome C is released. This combines with apoptosis activating factor, and this results in a cascade of reactions which results in apoptosis. And the final result is death of the ganglion cells in the retina, resulting in visual field loss. So the investigations for ethambutol toxicity are a comprehensive ophthalmic evaluation, including a best-corrected visual acuity, color vision, Amsler grid testing, pupillary reaction, slit lamp, IOP, a dilated fundus examination, visual field examination, visual evoked potential, which is very important, SDOCT, and color photo of the fundus. So unlike other toxic optic neuropathies, ethambutol toxicity can occur at a very short period. It generally occurs in doses higher than 15 milligram per kg, and symptoms usually start in 3 to 5 months. And majority of the patients present with bilateral, painless, symmetrical loss of central visual acuity and dyschromatopsia. So the visual acuity loss, it can be minimal or it can be severe. And the color vision loss, it could be one of the first signs, and it typically presents with loss of red-green color perception. Now, central vision loss is the most important visual field defect. However, other possible visual defects include bitemporal hemianopia. So this is the HFA 30-2, so showing the central scotoma, and this showing the bitemporal hemianopia. So initially, pupillary responsible may be normal, but later it can be sluggish. But relative afferent pupillary defect is difficult to elicit because changes are usually bilateral and symmetric. The optic disc in the initial stages appear normal, but as toxicity progresses, optic disc pallor will set in. So visual evoked potential, this is actually one of the most important diagnostic criteria, early sensitive diagnosis of ethambutol toxicity. So basically, ethambutol, it slows down the conduction, neural conduction to the occipital cortex. So in a VEP, you'll find that there's an increase in the latency of the P100 wave. P100 is the, at 100 milliseconds, the first positive wave. So when there's an increased latency and also a reduction in the amplitude. So VEP is actually considered an early biomarker. And studies have shown that VEP can be useful for detecting subclinical optic nerve damage in patients taking ethambutol. That is, even before the vision actually reduces, if you do a VEP, you may get some early results. So this is the SDOCT showing the ganglion cell complex. As you can see, there is severe thinning of the ganglion cell layer in both eyes, and temporal GCIPL. That is actually a reflection of the severity of ethambutol toxicity. As far as RNFL thickness, in the initial stages, it may be normal or even high, but in the later stages, it shows thinning. So there are certain risk factors. Not everybody on ethambutol goes into toxicity. So the risk factors are old age, higher dosage, longer duration. See, longer duration, like patients who are on spinal TB, they may need at least 1.5 to 2 years of ATT. Renal disease is a very important risk factor. Then low weight. Then systemic diseases such as diabetes, hypertension, malnutrition, and of course alcohol, tobacco abuse. Also the concurrent use of isoniazid, and also in preverbal children. So there is no effective treatment for ethambutol-induced optic neuropathy other than stoppage of the drug. But early detection of the disease and stopping ethambutol may prevent further deterioration. So the damage is reversible if discontinuation of ethambutol is done at an early stage. Around 30 to 50% patients show recovery to a variable extent after 6 to 9 months of stopping ethambutol, which means that almost 50%, a large percentage, will go on to irreversible visual field loss. That is why this is important. And visual functions may continue to deteriorate even after stopping the drug. So that can be very distressing for the patient and for the doctor. So supportive treatment in the form of vitamins, but the dose is important. Methylcobalamin, 1500 microgram, pyridoxine, thiamine, and also zinc and copper are helpful. So a little bit about epidemiology. There are 10 million cases of tuberculosis worldwide, of which a large percentage, that is 27%, are prevalent in India. And 55% patients will be on ethambutol. If you take a risk of 1 to 3%, that accounts for about 22 to 66,000 cases per year. So initially in India, TB treatment was started with a DOTS regimen. That is 6 months of ATT, 2 months intensive treatment with isoniazid, rifampicin, pyrazinamide, ethambutol, and a 4 months maintenance therapy of isoniazid and rifampicin. So ethambutol is given just for 2 months. However, due to drug resistance, WHO changed their guidelines. This was incorporated in India in 2016. And with this revised regimen, there was a marked change in both dose and duration of ethambutol, which led to an increased cumulative dose of ethambutol. So these are the changes in the revised National TB program. Here, ethambutol is given in both intensive and continuation phase, and the duration is increased from 2 months to 6 months, and dosage also from thrice weekly to 6 months. So ethambutol is given a fixed dose. I will explain. It may exceed the safe dose of 15 milligram per kg. Here, one tablet contains all 4 drugs. That is INH, rifampicin, pyrazinamide, and ethambutol. In this following milligram, 75, 150, 400, and 275. So that means you really cannot separate ethambutol alone. So in this revised program, again, in the intensive phase, all 4 drugs are given. And in the continuation phase, 3 drugs are given, only pyrazinamide is stopped. So you can make out that ethambutol is given in both intensive and continuation phase. But the good thing is that they are divided into weight category. So for example, if a patient is say 60 kg, he has to take 4 tablets of this, both intensive and continuation phase. But if this is what I've written in brackets is the approximate dose, so that comes to like 22 to 20 milligram, which is actually higher than the 15 milligram per kg dose that is recommended. So that means in this revised program, there is a higher chance of toxicity. Now, taking cognizance of this, neuro-ophthalmologists and other specialists in July 2020, under the aegis of Indian Neuro-Ophthalmic Society, they gathered together to deliberate on prevention, diagnosis, management of ethambutol toxicity. They came up with a consensus statement, and that has come out as an article in IGO. So these are the important recommendations. First is that there should be an increase in the awareness of physicians, because physician is the first person coming into contact with the patient. They should ask for risk factors, and patients should be informed about the ocular toxicity, and they should report as soon as they find a decrease in vision. Patients should be referred for ophthalmic evaluation before starting treatment. Then the patient is aware that such a possibility can happen. High-risk patients should be followed up every 2 months. So the treating physician, he is the key person. He should ask for a decrease in vision at follow-up visits, and ideally just a visual acuity chart in his office, he can do a quick vision assessment, and ethambutol should be stopped at the first sign of ocular toxicity. And as I said earlier, basic investigations, visual acuity, visual field, OCT, VEP should be done. But the important thing is that patients should be taught to check vision at home. Even just giving him a simple Amsler grid would be helpful. Now, children are a separate category. Though the risk is less, it is challenging to diagnose toxicity, especially in preverbal children. So parents should monitor the child's vision. So the take-home message is that there should be an increase in the awareness among healthcare professionals at all levels. Patients should be informed of ocular toxicity. The patient should be referred for ophthalmic evaluation before starting treatment at 3 months and 6 months, whereas high-risk patients should be evaluated every 2 months. And early diagnosis using a sensitive indicator such as VP is critical to prevent irreversible visual field loss. Ethambutol should be stopped at the first sign of ocular toxicity. If vision deteriorates, INH should also be stopped, and patients should be informed that the visual recovery may be gradual and may take up to 2 years, and supportive treatment in the form of vitamins. The key factors are awareness of ethambutol toxicity, early detection of ethambutol toxicity, and stoppage of ethambutol at the earliest sign of toxicity. Thank you.
Thank you, Dr. Anya.
Methyl, actually, many people are just giving neurobion. That is not sufficient. You have to give, you should give the correct dose, 1,500 microgram of methylcobalamin. You can also give no, tablet is there. Yeah, Mega Neuron or even Rena Plus. But you must check, they should, because any multivitamin will have so many vitamins. But yeah, pyridoxine 40 milligram earlier used to be given along with the ATT, but now it's not given. But you can give it as an addition. But the actual thing is methylcobalamin, and you can also give now Neurobion. Actually, there's Neurobion and Neurobion Fort. Actually, Neurobion has a higher content of thiamine and riboflavin, but it is not available. Everybody is giving Neurobion Fort. So maybe just giving something containing methylcobalamin, such as like Rena Plus, that is easily available, and also a Neurobion or Neurobion Fort. That is, but you have to tell the patient that it will be a long term. Many of them go into Ayurvedic treatment or homeopathy, but most of them recover to a certain extent by within 1 year.
Thank you, Dr. Anna. What is happening is usually the pulmonologist send the patient before starting an ATT for ophthalmic evaluation, and we record the color vision, visual acuity, and sometimes even field, and we ask them to start the treatment. What is happening is once the patient develops a visual symptoms, the medicines they are getting is from these ASHA workers. And these ASHA workers are not aware that ethambutol can have this toxicity, and they are more worried about the tuberculosis. They ask them to continue the medicines without looking into the ophthalmic features. So better ask the patient whenever there is an ocular symptom, you immediately report and meet the physician whether to stop the medicine or change to another drug. Majority of the medicines they are getting is not from the pulmonologist directly. First they start the treatment and then they send the patient to this ASHA workers, and they are getting the medicines from the PHC. Usually we see patients who have started 2 months, after 2 months they get defective vision, and this ASHA workers told them to continue the treatment. And when we saw the patient, it was optic atrophy. So if you diagnose early, then some amount of the vision may be preserved. So better to ask the patient whenever there is a visual symptom. Don't continue the medicine, report to the pulmonologist, ask them to whether to change it into some other combination.
And they won't
No,
send
no,
also before
it is
starting.
not
They
the
won't send also.
pulmonologist, it is ASHA workers, because this medicine is free and they are getting from. Because they are getting the medicines free from the PHC, from the ASHA workers, not directly from the physician or.
I think in the
Because they are more bothered about the TB status, not about the vision. So they ask them to continue the medicine. It is always better to finish that 6 months course. That is what these ASHA workers are telling. That is, if you stop in between, that can lead on to resistance. They are more bothered about the drug resistance and continuation of the